So we've established the different mechanisms of glomerulonephritis. And remember, we're really talking about inflammation at the level of the glomerulus. And basically, I want to try and integrate the clinical picture with the pathology and then give you the diseases that are responsible for each. So glomerulonephritis is a pretty general term. It includes a lot of other diseases, and these diseases could present differently. And I want to sort of frame this talk among the following spectrum. And so some diseases could present with just isolated hematuria and not much decline in kidney function. Some diseases can present with a nephritis, with or without the nephrotic syndrome. Some diseases present with an acute nephritis, so probably hematuria, pyuria, proteinuria, and some renal failure. And some diseases present as the rapidly progressive GN with fulminant renal failure with hematuria and proteinuria. And so we're going to sort of use the spectrum as our framework today. And it should be said that this is a little simplistic in order to make the teaching a little bit easier, in that real life is not always this simple. Some diseases have a very heterogeneous presentation, and they can jump categories at any time. But for the purposes of this video, I think it'd be easier to present it like this. So first, let's consider a patient who has just isolated hematuria. And let's assume you did the hematuria workup and ended up ruling out extrarenal causes of hematuria, and you really suspect glomerular hematuria. So these are the things that you should consider. Number one, a basement membrane-based disease, or maybe there's a mesangial proliferative GN occurring. So one thing to consider are diseases involving thin basement membranes, and so this includes Alport syndrome and also the thin basement membrane disease. And so I want you to pay attention to this picture here. And the basement membrane in this glomerulus is thinner than you've seen in other pictures. So just compare it to the one right next to it. You can see this is a little bit thicker. So this basement membrane is thinner than it should be. This is due to diseases that affect the collagen in the basement membrane. And so Alport syndrome is one disease that is genetic. So it's typically X-linked, but it can also be autosomal recessive. So this is a mutation in alpha chains of type 4 collagen. And so these mutations result in defective assembly of the collagen chains that are essential for function of the GBM. So in Alport syndrome, early in the disease state, you see the thin basement membranes, but actually these patients eventually, maybe in middle age, in their 30s or so, develop proteinuria and actually progressive kidney disease. And there's a good chance they would end up on hemodialysis. So early, it looks very thin, but later it can get actually thick and thin in separate segments and sort of has this lamellated structure to the basement membrane that looks really disorganized. Patients with the thin basement membrane disease, this is sort of a catch-all term for patients with benign hematuria due to thin basement membranes, and a lot of them actually end up being carriers for the Alport's allele. So they may be carriers for autosomal recessive Alport's disease. They may not have the full-blown disease, but they have thin basement membranes and just hematuria, and generally a pretty benign course. So next, in our patient with isolated hematuria, let's say we saw mesangial proliferation instead of thin basement membranes. So if we saw mesangial proliferation, I want you to consider these two diseases, IgA nephropathy and class 2 lupus nephritis. And so, look, here's the mesangium, and you see there's more cells here than there normally should be, like there are here. And so mesangial proliferation is a subtle form of glomerulonephritis. So this is one instance where I'm simplifying things, and so I'm doing this because IgA nephropathy can really exist anywhere on this spectrum, with the exception of maybe the TMA, but it can cause acute nephritis and crescentic disease. But, like a good sort of board question would be, a young person with isolated hematuria, and on biopsy there's mesangial proliferation, and if it's not a mild version of lupus, it's probably IgA nephropathy. So IgA can do anything, but I'm putting it here for ease. So what is IgA nephropathy? It's actually caused by immune complex disease. So what's happening is that there's IgA1 that's circulating in your body, and there's actually deficiency of sort of these galactose sugars on the hinge region of this antibody, and it's actually antigenic, and so it serves as an antigen for other things to bind it, like IgG or another IgA antibody. So basically IgG will bind this aberrantly glycosylated IgA1, and that will form these complexes which will deposit in the mesangial area, causing the proliferation and the GN. So on our biopsy specimens, we can stain using immune fluorescence for different components, and if we stain for IgA nephropathy is positive for IgA immune complex deposits, and so if we see deposits in the mesangium, that would make the diagnosis. So what if we saw mesangial proliferation but everything stained positive? Well, that would suggest class 2 lupus nephritis. So what makes it class 2 is the mesangial proliferation here. And the suggestion that it's lupus is the so-called full house pattern where everything's positive. IgG is positive, IgA is positive, IgM is positive, and typically the dominant one is IgG, or it's co-dominant with IgG and something else. And then there's evidence of complement activation like C3 and C1q, and so finding deposits that stain for everything is highly suggestive of lupus nephritis. And so there is a minimal mesangial lupus, class 1. Essentially that would be maybe finding all the deposits in the mesangial area with not much or any proliferation. But if there's proliferation, then it puts it into class 2. So next it's worth talking about the membranoproliferative lesion. And so this disease could present, with nephrotic syndrome, with or without the nephrotic syndrome. So heavy proteinuria with a little bit of nephritis would be a good sort of board kind of question to present MPGN. So membranoproliferative glomerulonephritis, we just say MPGN for short, but this is more of a histological lesion than an isolated disease. So if you ever see this or hear about this, the next question you should have is, well, what does it due to? It must be due to some other disease. And so basically it's a disease caused by subendothelial and mesangial deposits. So look, in yellow here I put the deposits, and so these are subendothelial deposits because they're on the endothelial side of this basement membrane right here. And then there's also mesangial deposits, and so this can occur due to chronic infections or chronic antibody production that's depositing here. Or dysregulation of the alternative complement pathway could result in complement deposits that produces the inflammation. The hallmark appearance of this lesion is that there is mesangial cell interposition in between a new layer of basement membrane and the old basement membrane. And so this is what makes it sort of have the odd name of membranoproliferative glomerulonephritis. So we have hypercellularity of these mesangial cells, but look, they're sort of growing and extending in between basement membrane and a new layer of basement membrane. And so you can see that the cells in response to the injury are producing a new layer of basement membrane. And so what happens is that, see, you have two basement membranes, and that on light microscopy, the capillary loops look really thickened, and you can actually see two layers sometimes. And that's what people mean when they say tram tracking, because it sort of looks like a railroad track or tram track under certain stains at the microscope. So when you see MPGN or hear about it, I want you to think about it in terms of two mechanisms. One, an immune complex mediated process, and the other, a purely complement mediated process. So immune complex mediated means immune complexes are involved, and complement would be dysregulation of the alternative complement pathway. So in terms of immune complex mediated disease, chronic infections can do this, like chronic hep C or chronic hepatitis B. Also, cryoglobulinemia can cause the MPGN lesion, and especially chronic hepatitis C can cause MPGN with the cryoglobulonemic lesion. Also, a monoclonal gammopathy, so this is like multiple myeloma or a plasma cell dyscrasia that produces way too much of a single antibody that tends to cause the deposits that will cause the MPGN lesion. Also, patients with autoimmune disease, so that includes lupus and others. And then also transplant glomerulopathy is when a patient with a kidney transplant has sort of chronic immune deposit due to alloantibody directed against their kidney graft. And so this can occur, and it's sort of a form of MPGN where we see duplication of the basement membrane and cellular proliferation. So all of these are mediated by subendothelial deposits and mesangial deposits that drives the immune response. So next, for diseases that are complement mediated, remember these are diseases that are collectively called the C3 glomerulopathies, and it's due to dysregulation of the alternative complement pathway. So C3GN is one of them, and another one is called the dense deposit disease. So either one can cause the MPGN type of a lesion, where these deposits, they're not driven by immune complexes, but complement, rather C3, due to dysregulation of the alternative complement pathway. Just to reiterate the structure here, what's happening that makes MPGN unique is that there's subendothelial deposits, mesangial deposits, and then mesangial proliferation, endocapillary proliferation with the sort of cellular projections separating new basement membrane from old basement membrane. And all this inflammation eventually causes podocyte effacement. So you can see I made the podocyte sort of sick looking, and instead of having the nice little foot processes here, it's flat, and so eventually this will cause proteinuria, causes nephritis, and progressive renal disease.